Dr. Ng completed endocrinology fellowship training at the University of Pennsylvania in 2001. He joined the faculty at the Division of Endocrinology, Diabetes, and Metabolism at The Ohio State University in 2006. He runs a metabolic bone and mineral outpatient clinic where he sees patients with rare bone disorders such as hypophosphatasia and common conditions such as osteoporosis. He's done research and published articles on HPP. He's a former program director of the Endocrinology Fellowship. He enjoys teaching, from continuing medical education to medical trainees, as well as his patients. After holding the first regional soft bones meeting in 2017 at OSU, the organization decided to roll out the idea across the US. OSU hosted the Soft Bones National Meeting in 2018 and our last regional meeting for Midwest 2 in 2019. Dr. Ng, take it away.
Thank you, Sharon. Yes, it's an honor to be here and to have worked with you over the past few months on this program. Sharon, you are an energizer bunny.
Thank you.
I'm going to start off here on a kind of a HPP 101. Every time these meetings are held, there are people who have seen this kind of thing many times over, and there are also people who are a little bit newer to this, and so this is more on the introductory level. I'm going to jump right into this. So thank you for sharing your morning with all of us. To try to engage, I thought I'd do a little game show kind of format. We're not going to do any questions on movies or world literature, TV, poetry, or planet Earth. It's only the right-hand column on HPP. So there will be 5 questions, and here are the answers. And I'd like to see the participants answer in the chat as we go along. Okay, ready? All right. HPP for 200. HPP is an example of this class or type of genetic disease. Let's see your answers.
Coming in.
All right, so this is the answer that I put to this question. What is an inborn error of metabolism? HPP is a genetically determined condition. These sorts of conditions can involve single genes, of which we know about 7,000 of these, and the actual causal gene is only found in about a half. Of these single gene conditions, more than 550 are what are called inborn errors of metabolism. So this is a kind of problem in which there's a block in a metabolic pathway. In this slide at the bottom, there's an X and a Y. So this the substance called a substrate X can turn into another one, a product, or Y, and an enzyme helps to move that reaction from going from X and Y. The DNA in our body is divided into genes, and genes can make various proteins, and one of those types of proteins is an enzyme, and the enzyme will catalyze this kind of reaction. If there is a problem with that gene that makes the enzyme may not be working very well, and so there's a block in what's normally going on, and we have a buildup of the substrate, and there'll be less of the product. Now, I just wanted to, as I was putting slides together yesterday, inborn error of metabolism. I'm a parent. Luckily, my kids are healthy without any known inborn errors of metabolism. But if I had to talk to my child about this, or they were on the internet and start to read about this, this could come up. Dad, am I in error? So you might face this kind of question in the future with your kids. It's an error in the enzyme. This is not a description of the child. In genetics, we used to use the term mutation, and that implies if a person has a mutation, they're a mutant, and that implies some negative connotations. I wish there was a better term for this than inborn error of metabolism, but this was coined so long ago and just keeps going on in the medical textbooks. So HPP hypophosphatase is a rare, inherited, lifelong, potentially life-threatening metabolic condition that affects the bones. Its prevalence, some estimates show 1 in 100,000 live births. In some populations, one in particular in Canada, some Mennonites, it's more frequent, 1 in 2,500. So it kind of depends on the population. This is a website that's worth copying. I think the slides will be available, or this webinar will be available later, but this is a database for the ALPL gene that's kept in Europe. Right now, there are more than 450 mutations that are disease-causing in this database. Okay, moving on. HPP for 400. In HPP, this enzyme is defective. All right, I see it. I see an answer there. Great, Sherry. Okay, what is alkaline phosphatase, or ALP? So HPP is due to a defect in the enzyme alkaline phosphatase, even more specific, tumor non-specific, tissue non-specific alkaline phosphatase. So this enzyme is a protein. Enzymes are proteins that help drive chemical reactions, and this particular enzyme is a phosphatase enzyme. Phosphatase is a type of enzyme that will remove a phosphate group off of another molecule. On the lower right, I'm showing the chemical formula for a phosphate group. On the left is a pictorial of what the alkaline phosphatase enzyme might look like. And the hallmark of HPP is this low ALP level. Here is a table of some reference ranges from the Mayo Clinic site. Note that it's different between males and females by age. And as we get older, the reference range can change. So it's important to know what is the reference range at the time of the blood draw to make sure that this number is normal or outside the range. For OSU, a person 19 years or older, I'm showing here the reference range, 32 to 126. HPP for 600. In HPP, defective ALT leads to an accumulation of this compound.
I hear the typing. They're getting their answers in.
Okay. All right, I'm gonna move. So this is a little bit of alphabet soup, but any of these could be correct. What is pyrophosphate, or PPI for short? What is PLP? That's the shorthand for pyridoxal 5-phosphate, otherwise known as vitamin B6. What is PEA, or the longer name for that, phosphoethanolamine? Not all of these are available to be measured in the clinic. PLP and PEA can be. The PPI, pyrophosphate, is a research tool. So I'm showing here the ALP enzyme, and it's acting on this pyrophosphate molecule, and it'll cleave this molecule into two molecules of phosphate. So that's what it does normally. And it is doing this normally in the bone. I'm showing here a tissue sample of growing bone. So these kind of darker purple cells are called osteoblasts, and they are making new bone. Bone is not hard when it's first made. It's a protein matrix. It's soft, actually, when it's first secreted by these osteoblast cells. And over some months, it takes that long for the minerals to come in and make this tissue turn from something that's soft to a tissue that's hard. Now, we want to make sure that these processes are taking place at the right time, at the right place at the right time. And so normally this pyrophosphate is present in the bone and preventing mineralization from going on. But when the bone is newly forming, that's the time when we want the inhibitor, the pyrophosphate that's inhibiting the mineralization process, to not be present, not work to inhibit mineralization. So in the setting of newly forming bone, alkaline phosphatase is active, and it's normally working to break down the inhibitor of mineralization, the PPI. So with the situation of HPP, PPI accumulates, and that will continue to inhibit the process of normal bone mineralization. So it's not mineralizing, it's not becoming hard normally. Okay, so classically, HPP is felt to be a condition of the skeleton. You can see that in this child's X-ray, there's some bones, but look here, there's very little, can't really see the bone. It's there, it's just not showing up on the X-ray because there's very little mineral. Rickets is the situation of bowing of the leg here, the femur bone, and can lead in HPP. There are fractures. They could recur. They could be non-healing. Here's this example of a pseudo fracture in which many years after this rod was placed, the fracture is still present. There can be bone pain. The stature of the person may be shorter than what otherwise would be genetically determined. Okay, moving on, HPP for 800. In the diagnostic classification system of HPP, this is the mildest form of HPP. Odonto, yes. Okay. We'll have a whole series of talks in the next hour on dental manifestations of HPP. This is what a tooth that would come out would look like. Here is a tooth that has the roots connected to the tooth that really shouldn't be. Normally the baby tooth is coming out after age 5. So our dental colleagues have taught me that before the age of 5 is not normal. This odonto HPP is a situation in which this is the only manifestation that is, at least at the time seeing the patient, the only manifestation of HPP that's known. So this would be on this side of the spectrum that's less severe, and here's the other opposite side of the spectrum, more severely affected individuals in the perinatal. So the classification includes perinatal, infantile, childhood, adult, and there'll be a little bit more details in a moment. HPP symptoms can vary from patient to patient, and even in the same family where the same individuals have identical mutations, the clinical manifestations can be different, and some people more affected and others less affected. And not every person with HPP has every symptom of HPP that's on this whole list of symptoms that can occur. So this is a condition that has a really wide spectrum of severity, probably the widest of all the conditions that clinicians will manage. Okay, the perinatal form, this is the really severe type, and it's often lethal. At least it was often lethal before we had enzyme replacement. If folks have searched on the internet, you Google HPP and you look at images, this is the kind of patient that will commonly show up if you do that. Now, in the prenatal form, there's this other type called benign prenatal HPP, where if you image with an ultrasound during pregnancy, you might find some problems in the bowing of the bone, for example. But these are patients who will improve after birth. And figuring out who has a benign course or who has a more severe course, that's for the perinatologist to help answer. In the infantile form, and this is up until the age of 6 months of diagnosis, they may not be born with an obvious problem, but as the child grows, we might see some of these signs and symptoms of short limbs, bowed legs, a skull that is soft. They could have seizures. They could have breathing problems, kidney problems, feeding problems, and therefore difficulty gaining weight. If the diagnosis is made after the age of 6 months, we call this childhood HPP. And here is a list of common manifestations in this form: shorter stature, bowed legs, delayed developmental milestones. For example, the age of starting to walk is later. Early loss of the baby teeth, muscle pain and weakness, pain in the bones, pain in the joints, swelling in the joints, and fractures or pseudofractures. Adult HPP, and in my practice, I see plenty of patients whose signs and symptoms are showing up after the age of, at age 18 or later. That's the definition here. There can be an early loss of that baby tooth, the odonto, as well as adult teeth are being lost. Stress fractures of these bones in the feet, the metatarsals, is a common situation in adult HPP, and we'll have a whole talk on this with Dr. Atway in a few minutes. These are fractures that are recurring and maybe poorly healing, or multiple toes are affected. There can be these pseudofractures. I think of these as stress fractures, and they're commonly at the lateral upper femur, so kind of at the sides of the thigh or the hip. HPP patients adult patients can present with fractures, weakness in the muscles, pain in the bones, joints, and muscles. Okay, last question, which is double. There's an X-ray of an elbow. Points to what manifestation of HPP? This stuff here. So this is probably the hardest one, calcific periarthritis. So it's a bit of a conundrum. You have normally hard tissues which are soft. You know, the bones don't mineralize and you get soft bones. Yet these soft tissue areas become hard. And if it's around this joint, this is the humerus above the elbow, radius ulna below the elbow. So this is the joint space at the elbow, and calcification around that joint. Now, exactly why that happens, we don't really know yet, but it is a clinical manifestation, and this can be painful in the joint, in and around the joints. Okay, so manifestations of HPP that are not in the bone. So talked about dental. These newborn children who are severely affected can have early respiratory failure. There can be neuromuscular, neurological symptoms, seizures, muscle weakness, gait problems. There can be problems in the joints, cartilage, tendons, or soft tissues. In the previous slide was this calcific periarthritis. Here's an example of chondrocalcinosis. So right in the joint space itself, you can see this line that's calcium. It's really not supposed to be there, chondrocalcinosis. There can be attacks of what are called pseudo gout. So a person who has gout can have joint attacks in the joint where there's acute pain, but that's a certain kind of crystal that forms in that joint. There's another kind called calcium pyrophosphate deposition or pseudo gout that can occur here too. And calcification can occur in the kidney. I've shown this slide, which is kind of this classic slide of extra skeletal manifestations, but we're more and more recognizing other neurological kinds of signs, symptoms, including things like headache or fatigue. There was a paper by Catherine DeHeer on this not too long ago, and she's, dizziness and vertigo and depression and anxiety. So these other things are emerging more and more as we're learning more about HPP systematically. So finishing up, a diagnosis of HPP is suspected. Certainly if somebody else in the family was already diagnosed with HPP, or perhaps the pediatric dentist recognized an early loss of a tooth, or there's an X-ray that's done for some reason, and it's showing that the bones are not mineralized well, or there may be a fracture or deformity. The low blood level of ALP is a hallmark. Note that the normal range depends on the age, and in general, it's higher in a younger person. ALP may be altered. It may be higher right after a broken bone or during pregnancy. The placenta makes the ALP as well. In chronic and acute liver diseases, this enzyme may be higher as well. And ALP may be lowered. So if you're on prednisone, some steroid therapy long-term, this can lower the ALP. Profound hypothyroidism, situations like heavy metal poisoning, radioactive types, starvation, certain deficiencies and critical illness if you're really sick in the intensive care unit or have had a lot of transfusions. These can be situations that will lower the usual amount of ALT that's in the system. And so this is my last slide. This really does take team approach to help manage many patients with HPP. I'm really glad to be part of Soft Bones. Every time I do one of these things, it's actually a nice opportunity to bring other people on board here. I've just shown some folks I have collaborated with within OSU or nationwide over the years in HPP. Getting her slides up, I'll introduce Pam. She is a licensed genetic counselor, did her training at University of Pittsburgh, and she's currently on faculty in our Division of Human Genetics. She provides genetic counseling services within a multidisciplinary clinic focusing on neuroendocrine disorders, and does research, has research in the genetics of thyroid cancer and other endocrine conditions. Because she is, because I'm an endocrinologist and we work together on, say, hyperpara patients, I pulled her into the HPP world, and it sent many folks her way to try to define more clearly the genetics around that patient. Pam, take it away.
Thank you so much for that introduction, and thank you to the organizers for inviting me. And for the sake of time, I may go a little bit quickly, but I am available if there are questions afterwards. So just a quick review on the genetics of hypophosphatasia. So it's due to variants or mutations. Those words, we use them kind of the same. And the ALPL gene, which is located up here at the top of chromosome 1. And I show this picture because I think it helps illustrate this concept of why we have 2 copies of this gene. We have 2 copies of that chromosome. We get 1 from each parent. A quick review on genetics. Within our chromosomes, we have these strands of DNA, and a gene is a piece of that DNA. We like to think of it as an instruction manual or a recipe. So within the gene, there are these exons, which are kind of the chapters, and it really kind of gives the instructions for which amino acids combinations to put together to make a specific protein. And so the ALPL gene, as we've already talked about, makes the tissue nonspecific ALP enzyme. And this, I show this picture here at the bottom because I think it's a good visual to kind of help understand why we see such variability in the impact of different variants or mutations. So the gene product is actually kind of half of the enzyme. So 2 of these gene products come together to make 1 functional enzyme. And so there's a lot of different places within this complex where something could be slightly different, and the severity is going to be different. So if it's something that impacts those 2 halves being able to bind together, or if it impacts one of the other active binding sites in the enzyme, or just kind of changes the shape so that the binding is less effective. That's part of why we see so many, such variability in the impact from the many different mutations in the gene. So different kind of spots in the gene where that letter can be different. Genetic testing is available to look at the ALPL gene done with a DNA sample, so blood or saliva. During the pandemic, we're doing a lot of testing with saliva samples because it's easy for folks to do from home, where we send a kit in the mail. It's well covered by insurance, and overall the cost of genetic testing has come down dramatically over the years to where, if for some reason, a patient were actually paying for the test themselves, which happens very rarely, it's around $250. It may, when we order testing, we may just look at that ALPL gene because, Dr. Eng, when he sends the referral, he's pretty sure that this is the condition and that's really what we focus on, or sometimes we're including other genes. And this testing, just to kind of make a distinction, is very targeted testing, high quality. The labs that do this testing go through extensive certifications because they know that this information is used in medical decision making. Very different from other types of genetic testing that you may see advertised online, like 23andMe and Ancestry and those types of things, which are looking not at this kind of level of detail. And so basically the labs that do the test know what that genetic code typically says. They take a patient sample and they're basically proofreading, going through letter by letter, looking to see if there's anything different than what they would expect to see. So these are the possible results that come back from genetic testing. On the left, you'll see kind of what the actual words on the report are. And then on the right are kind of, the overall take-home message that we're often talking about with patients. So it could say, yes, we found a pathogenic, or one that we're pretty sure is pathogenic variant, so a mutation that would make that gene not work, and kind of be an explanation. So maybe one or maybe two, kind of depending on the situation. On the other hand, it could say, no, everything looks normal, we didn't find anything. And so then we're maybe going back to the drawing board, thinking about other genes, and also knowing that the testing isn't 100%. There'll be some people with HPP where our technology just isn't smart enough yet to find the specific mutation. And then we have these uncertain findings in the middle, where there's something different about the gene, but we don't have enough data to know with certainty, is that just something normal? Kind of everyone's DNA is normal and unique from person to person. Is it normal variation? Or is it actually a mutation that just hasn't been seen enough times before to know that that's the impact? So those can be some frustrating situations as well. And I like to point out that this kind of tiers of results, when we get this uncertain, it's not where, is it a more mild mutation? It's more having to do with the level of evidence. So this isn't something, kind of speaking about kind of the severity of the impact, but more how sure are we that this is something that would make that gene not work properly. As Dr. Eng mentioned, there's a group in Austria that has a database where they maintain kind of data related to the different types of variants. And here's a pie chart. We know that the majority of the mutations in the ALPL gene are what we call missense variants, where there's just one amino acid that is changed. So the rest of the protein, the rest of that enzyme is essentially normal, but there's something that's changed. So where, we're going to see differences in how it's working, how it's binding. And I know Dr. Eng talked about kind of the different presentations and the the kind of categories that have often been used, and really trying to think of it, if we look at kind of the spectrum of the condition when we're thinking about inheritance pattern, knowing that if there's two mutations, then that's often going to be kind of where we see earlier onset, versus if it's later onset, more likely to be due to one mutation. And these aren't hard and fast rules, but just kind of general trends. And usually we think that's due to kind of the degree of the enzyme residual activity that's present. So, I think it can be somewhat confusing when we have these different inheritance patterns, and I think thinking of it along that spectrum can hopefully help. So in some families, we may see that there are two mutations. We may have an affected individual and we find two mutations, and most of the time this one came from each parent. And so that's what we would call a recessive inheritance pattern. And so those parents would have a 25% chance to have another child with the same condition. But then where it gets a little bit tricky is for the parents, if they have one mutation, are they, have a risk for the more mild end, or are they going to be purely asymptomatic? On the other hand, an autosomal dominant, we think just one mutation is sufficient to cause a clinical impact. And so usually this is where it's coming from one parent or the other, not both. And in these cases where we can see that more transmission through the generations, where there's that 50-50 risk in each pregnancy. And typically this is not impacted by, the sex of the parent or the child, kind of males versus females. So I guess some key summary, there's significant variability in the impact of different ALPL gene mutations. Genetic testing can help pinpoint those mutations and can help with testing of other family members. It's often not required to establish a diagnosis. It can be kind of the biochemical evidence can sometimes point towards the diagnosis, but it can help just kind of, make sure that, yes, this is definitely what we're dealing with. And then, like I said, I think a real benefit is then trying to figure out who else in the family may have that mutation. Like we said, most people who have the biochemical evidence of the condition will have a mutation, but it's not 100%. And the genetic testing, we're really not able to predict the severity. We'll see folks who have the same mutation and may have differences in their severity. There's some trends, but it's not something where we can really give specific information, because we think there are other genetic, environmental, just differences in our metabolism that are likely going to impact the clinical presentation. So definitely an area that there's research work being done, but that we still have more to learn as well. And there's a great resource from Soft Bones. They have a pamphlet that goes over the genetics. That's quite lovely. And some of the inheritance patterns pictures I showed were pulled from there. So it's a very great resource for families.